This
bicarb
conference will
administration.
now be recorded.
All right. My topic is effectiveness of sodium bicarb on mortality and morbidity on cardiac arrest patients. It's a systematic review and meta-analysis. I didn't know how many people we were going to have and what spectrum of training they're in, so I wanted to go over what the evidence spectrum is. Obviously, there's expert opinion where there's no real science based on it, but logically it makes sense. Then you go to case series, case reports, where they've described actual events and how it played out. These are usually one or a couple cases, which is pretty low quality evidence. And then you go to the observational studies, and then the non-randomized followed by randomized trials. And then the systemic reviews and meta-analysis are usually the highest quality of evidence we have because they take a bunch of trials that have already been done and look at it and review it, and they may do their own separate analysis based on those trials. So this study, what they did was they searched through a database, and then they had only a couple inclusion, a couple exclusion criterias, and all the studies they were looking at had two arms, one with sodium bicarb and one without. So they included all adult cardiac arrest patients that were non-traumatic arrests, and they got bicarb. And they excluded pediatrics, people with existing acidosis, like someone in DKA or septic shock that were already acidotic prior to arresting, those who were intoxicated, and those on drugs. So when they did the searching, they found 849 articles that may have matched what they were looking for. After removing the duplicates, they got down to 714 studies. And when they started looking at all their inclusion and exclusion criteria and those that would be eligible for the study, they got up to 15. From those 15, 9 were excluded because one showed they gave sodium bicarb through the intracardiac route. I'm not sure how they did that. One compared high dose sodium bicarb to low dose, which is not what we're really looking for. One had the outcome of pH and base change, which doesn't make sense for any study because what we're really looking for is, do they live to hospital discharge or neurological outcomes? That's really all we care about. And then 5 of the studies were removed because they had different survival things. One was survival to an hour, one was to the ED, one was to admission, one was 14 days. Again, we don't really care about those outcomes as long as they have neurological outcomes. So at the end of it, they only got 6 studies that they included in this meta-analysis. The meta-analysis only had cohort studies. Some were prospective, some were retrospective, just so we can go over what a cohort study is for those who don't know. So a prospective cohort study is when, say on this example, you're looking for ways to understand what causes heart disease in women. So you enroll both obese and lean people, so 2 different criteria, and you follow them over time and see which people get heart disease. And that's how the prospective works. The retrospective is you already have the outcomes. You have everyone who, in this case, do chemicals use in, sorry, I got to minimize this. Can't read it. Does chemical use in manufacturing increase the risk of death? And they look at all the people with the positive findings, and they go back and look at employee records to see who has been exposed and who hasn't been exposed. And so that's a retrospective cohort. So in this study, they have the 6 they included here. We're just going to go through criteria. In the beginning, they have in the studies, it goes from 1995 to 2017, so it's a wide spectrum of when the studies were done, and some were prospective and some were retrospective. The inclusion and exclusion criteria specifically for each study are included there. They're all very similar in what we talked about earlier. And then there's the country where the study was done. So there's Canada, US, Taiwan, Hong Kong, Korea, and Canada. So North America and Asia. The median age was very similar to most studies, between 65 to 71, and the sample size varied between the studies. So what we really want to look at is survival to discharge, the biggest, that's the primary endpoint that a lot of studies look for. So they show the odds ratio. So just so people who don't know what an odds ratio is, an odds ratio of 1 means the 2 factors are independent of each other. So sodium bicarb and survival to discharge are independent of each other, is what an odds ratio of 1 is. If it's less than 1, it means there's an inverse proportion. So the more bicarb you give, the less likely they will survive to discharge. And the higher the number is, so if the odds ratio is 2 or 3, there's a positive correlation. So the more bicarb, the more likely you are to survive to discharge. So if you look at the studies, survival to discharge in the first study was 0.21, so less likely to survive. Then 0.58 was the second study, but that's to ROSC, which showed less likely to get ROSC from bicarb. You go down, the increase in ROSC in the third study was 1.4, so it showed a positive prediction for bicarb, but the survival discharge was only 0.397. So they may get ROSC more often in that study, but they did not survive to hospital discharge more. More people died from getting bicarb. The Hong Kong study was the exception. It showed increase in ROSC with the odds ratio of 5.37 and increase to discharge with the odds ratio of 1.42. Those are pretty significant numbers. Obviously, the study only had 489, which is a lot less than some of the other studies, but it's something to think about. And then the other two studies showed an odds ratio of ROSC of 1.56, but no survival to discharge odds ratio. And then the other one was a low odds ratio showing there was worsening mortality with bicarb, or worsening survival to discharge with bicarb and ROSC. This is kind of just a chart. So this one looked at the first part. A shows return of spontaneous circulation, and B shows survival to discharge. And then the confidence interval, how the P less than 0.05 that you hear, what's 95% time it will fall between those two lines. So one is where they're independent. So you look at, in the beginning, return of spontaneous circulation, you see that most of these cases are around 1, with some variation to a little bit higher on one of the studies, including Chung 2015 with ROSC. But when you look at survival discharge, most of them fall below the odds ratio of 1, meaning a lot of the people who get bicarb do not survive to discharge. And then they pursued this a little bit further. They looked at before and after 2010, and same study. A is return of spontaneous circulation. B is survival to discharge. They may have a little more ROSC in after 2020 study or 2010 study compared to before 2010. It's a small sample size. Obviously, it's only 6 studies. But when you look at return or survival to discharge, pretty much all of them show a decrease in survival to discharge with bicarb, besides Chung 2015, which has been the exception. And then the other subgroup they looked at is Asian population versus North American population. This was where it got really interesting. The Asian population had an increase in ROSC, and if you look at survival to discharge, may have had a slight increase in survival to discharge based on 2 of the studies. One of them, Wang, has such a big confidence interval that's hard to tell if that's actually the case. So we can talk about it now, or I can keep going on and finish the journal club. They described the limitations as only the 6 studies were used. They were all non-randomized cohort studies. They have so many co-founders. They don't talk about shockable rhythm, time to bicarb, if it was witnessed, if they have comorbid conditions, when was the response time, the race, even though it has the location, doesn't have the race, what they did post-ROSC, if they were septic. There was nothing else on there. So this is not the best study. There hasn't been any good studies in bicarb and cardiac arrest, but it's a trend that it shows worsening outcomes with it. I think because of these trends, ATLS removed routine use of bicarb in cardiac arrest in 2010. So they concluded bicarb not associated with improvement in ROSC or survival to discharge. In North America, you get worsening ROSC and worsening survival to discharge rates, but there is some trend towards the Asian population or in Asian countries where they may slightly benefit from sodium bicarb, and it needs to be further studied, is how they conclude it. I'm going to open up to questions, comments, concerns.
So does anyone routinely use sodium bicarb? I think the answer to that is everyone does, but why? You know, looking at the study, anyone?
It's an interesting thing to think about because bicarb theoretically should increase your acidosis, which you get from cardiac arrest, but it doesn't fix the underlying cause. You may be fixing the metabolic acidosis that may convert into a respiratory acidosis when you're not really breathing. So in the end, are you really worsening these patients, which is what the trend seems to be going towards?
Yeah, I think this is reflected in a lot of the things with cardiac arrest is that we don't know what we think we know, at least. And when we're throwing a therapy just at the wind, you know, it makes sense that we're not getting any association with any improvement. I think targeted therapy, like if you have a patient who, you know, for the last 2 days has been in respiratory distress, maybe that might help. You know, someone who has another reason to have this metabolic derangement, maybe. But until we focus on targeted therapies, you know, throwing random drugs at people is not going to be associated with improved outcomes. I mean, I still use it, especially for prolonged cardiac arrest, because of that, the metabolic derangement from the cardiac arrest itself. But, you know, really we should be targeting our therapies.
Even in a lot of metabolic conditions like DKA, bicarb has been used for what people say pH less than 6.9. Even then, it shows maybe questionable benefit versus no benefit at all. So I don't really think, even at severe derangements, that bicarb really does much when your condition's that severe. But that's up for debate. There needs more studies, more research, but something to consider. It definitely has to be targeted. It can't just be a blank throw it at everyone.
Yeah, this is similar to like some of the other things that we do where, you know, you think about risk versus benefit. You know, what is the risk of giving it? You know, they're already dead. So giving them some sodium bicarb, while it may not improve their ROS, it may help. So the risk versus benefit is there to give it. But when we're studying these therapies, definitely, you know, just throwing at everyone, this is the outcomes we're going to get. Yeah, we reviewed last year the EPI study, basically the same thing.
So my counter argument to that is the no harm argument, I think, falls flat in terms of where when they have no neurological outcomes, they're brain dead or they've been down for so long, they get stuck in nursing homes. A lot of people don't make them DNR. That cost to the society isn't harm. And I think if we're going to give it, think about giving it early for the right indications, which we don't know yet. But if you're going to give it 40 minutes at downtime, it doesn't make any sense. At that point, they are probably brain dead unless they're young and you're just doing a Hail Mary.
No, I agree with you.
Anyone else, or should we go to the next article?
And the only other question I would pose with the administration where it correlates to lower outcomes, even by our own discussions, we're saying that we're using it, it's still used, but we're not using it as much. So are we seeing worsening outcomes because of the timing of when we're administering it? They're not administering codes that we get back because they're, you know, we don't get to that endpoint, whereas we're well down the algorithm, like, all right, well, at this point we've given, you know, we've been treating them for 25 minutes. Why not? So that might be part of the other reason why we're not seeing the benefit to it, or we're seeing worsening outcomes.
Yeah, that's a really good point. And none of the studies address when bicarb was given. And I think that can be studied because it's unknown. But giving it last ditch is obviously not working. And it's also worsening outcomes. So I don't see a point of giving it last ditch. Unless they're young, they may have a quality of life. It may be a toxidrome because they're young and you don't know. That is a subsect that I understand giving bicarb to. The elderly, cardiac arrest, unknown time down, no, I don't see a point to it.
Yeah, we can look at our own data or someone else's data and basically either replicate the study or even look at subgroup analysis of people who got the sodium bicarb early versus they got it late. I would probably venture to guess that most people don't get sodium bicarb early, and it might just be practice differences. There's certain people who give it early, and I would actually be interested in seeing the ROS rates for people who get it early versus late, and then more importantly, the survival to discharge rates for those same patients. So this is definitely something for the future to look at.
Yeah, there's not enough good studies on anything in cardiac arrest, and this would be an interesting one that I would follow if someone did it. It just seems it would take a lot of people in a lot of cases, and it would have to be multi-hospital to get enough data to make it worthwhile. But I think a whole Robert Wood system may be able to pull something up like this.
Yeah, I mean, we're working treated cases anywhere from 100 to 200 cardiac arrests a month for our entire system. So if we go back to even just April, we're looking at 1,000 patients. So we may have the breadth to be able to start looking at this.
Sounds like a future fellow research project. All right, I guess we can go to the next study if no one has anything else to say.
So I have some notes on the bottom, so I'm going to leave it like this. Don't worry, I'm not hiding any information. So I'm talking kind of on the same idea, but totally different. We talk about a lot of cardiac arrest data and a lot of studies. And I think something that COVID kind of highlighted is something that we've all kind of known as mental health in the EMS world. So this was a study that basically looked at the death notification and EMS burnout. Can I? Yeah, at least a little bit. So I don't have any disclosures. So cardiac arrest is something common to pretty much everybody on this call, EMS, physician, medical student, we've all kind of responded to them. We've all had to take care of it. We've all had to deal with it after, whether it's in a public setting, in the back of an ambulance, in an ER. We've all seen it. And then this is kind of what happens after is you wonder if you could have done anything different. You wonder, what else could I have done? Maybe I didn't use bicarb when I should have. Or, just you try everything inside the house and you have to tell the family. So that's this bottom picture. There's a lot of this, that goes on, and whether it's just a regular routine cardiac arrest call or, a school shooting or some kind of a major event, PTSD, depression, all this kind of stuff kind of weighs on everybody, and it doesn't get as much, or it's starting to get more meat behind it. There's an increased incidence of depression, PTSD, and anxiety, especially in EMS providers. Burnout is increasingly recognized for years now that it's detrimental to productivity. You actually lose a lot of providers because they just feel too stressed out or burnt out to continue doing their job that they probably love or once loved. And then on top of it is the outside of the work setting is, burnout's associated with family problems, substance abuse, legal trouble, which just kind of creates this vicious cycle. And historically, and this isn't a blanket statement, but just in general, providers don't always get training on how to do death notifications or how to manage their PTSD, or they don't use EAP even though it's been offered to them for years. and so you end up with a even worsening mental health issue. The specific study looked at, does training decrease burnout among providers? And this is specifically to death notification. From the study, they hypothesized that if EMS providers got training on how to give a death notification and how to manage that situation after, cardiac arrest or a bad call, then they would have lower, if they had the training, they would have lower risk of burnout, lower risks of PTSD, anxiety, and depression. These are the population that did the study. So it was a work between the University of Nebraska Emergency Medicine, the National Registry of EMTs, and they basically used the National Registry because then they could send it out to every National Registered EMT and paramedic. And what they did is they ended up having two groups. They had the BLS, which is just the basics, and then you had your advanced, which was your advanced EMTs and your paramedics. Those were your two subsets of populations first. They did not include MRTs because they didn't feel that MRTs respond as much to cardiac arrests. And then on top of it, they don't transport or don't end up going to the hospital with these patients. So that's why they focused with just the EMTs and paramedics and advanced. So they sent out 19,000 surveys using the NREMT database, trying to get an ideal population of 600 in the basic group and a 600 in the advanced group, so that they could have enough power to interpret the results. And that was expecting about, I think it was like 10 or 20% response rate. They also only, in the questions, they used only adult patients, not pediatric death notification. So one of the questions was, have you given a death notification in the past 12 months, but specifically only adults. They didn't ask about peds. They used the Copenhagen burnout inventory within their questionnaire and the longitudinal EMT attributes and demographic studies. And then the University of Nebraska specifically had added some questions that they trialed within their pre-hospital system to validate them for the study to kind of get some more data points. This is basically the end number of responses that they included in the analysis, which was about 1,500, so more than 600 in each group, which is great. They had some exclusions. Obviously, if you didn't work in EMS, but you're an EMT, then, how relevant is your data to the rest of the population? Are you not currently working at an EMS agency, et cetera, et cetera. So analysis, this is a table, but it's not exactly what happened. So what they did is they evaluated EMTs against paramedics and advanced EMTs. They then asked both of those populations to see if they were comfortable with giving a death notification and if they weren't comfortable. And then basically, if you were comfortable, if you felt prepared or not prepared to give that death notification. This was all part of that same survey. Then they did a bunch of statistics. So unlike Narav, I'm not going into all that data. They used Likert scales and everything else, but they basically did a bunch of the stats to get to these major results. So the average age of the respondents were 30 to 39, more male than female, which probably goes along with our experience in the pre-hospital setting. BLS and ALS male specifically were about the same number, but there were more BLS females, which is interesting. And I think that also goes along with just historically what we've seen. Makes sense. ALS providers had more than 5 years of experience, and many of them had more than 15. Again, it makes sense because you become an EMT and then you go to paramedic school, which is usually about 2 years. So you're already at 3. So you have a lot more experience than your BLS counterparts. There was a pretty good split between fire-based EMS, private EMS, and then what they defined as other, which is hospital-based or municipal or other, wilderness EMT even. And then 75% were 911-based services. Oh, this kind of got messed up. So what were some other major outcomes? So BLS, they were more likely to be rural, which even goes along with how New Jersey is. You know, you have a lot of these BLS agencies down south and in the western area where they don't have a lot of calls. So most of them didn't have a lot of notifications. Some had up to 5 in the past 12 months. You know, obviously in our areas like Newark and Irvington, you have a lot of BLS responding to these, but you also have a lot of ALS as well. And obviously they're going off of a different model. So they're not going off of 2 BLS and 2 ALS providers in an ambulance and then kind of doing that like Jersey does. They're assuming that either you have a fly car ALS or an EMT and a paramedic or like a fire service where it is similar to New Jersey. ALS, mostly urban, kind of makes sense with what we see, higher call volume. 77% had given at least 1 or more death notification in the past 12 months, with the majority of that fitting within the 1 to 5 range. And then this I took out from the actual study is how many reported burnout, and that's from a validated Copenhagen burnout inventory is how they calculated it. So it's not like I'm burnt out. It's they responded in their questionnaire, which correlated with burnout. And it makes sense. Your ALS are seeing higher calls, more acute calls, more death notifications. So you have a higher proportion of them that are reporting burnout compared to your BLS counterparts. It is also kind of a confounding factor because can you say it's the death notification that is causing it, you know, the burnout or increasing the burnout, or is it just the fact that ALS does a lot more critical care? So it's something I do think I go on to in a minute, but specifically to this study. So who got death notification training? So in the middle, we see that the initial EMS course was a pretty decent split, 50-50, that BLS and the ALS got it. I don't ever remember getting it when I was in EMT school or advanced EMT school. And then who got ongoing education, which was, you know, for ALS providers more so, which again, I don't have experience being in paramedic school, but would kind of make sense to me that you have a little bit more training. I know in medical school and residency, we had a little bit of training with that. And then this last highlighted portion where do you think that it would improve your, if training would improve your preparation to give a death notification? And that's, you know, kind of, it blows it out of the water, right? It's like 90% for both BLS and ALS. So on top of it, we talk about, you know, this is more keys to that. So, you know, they felt that the training would help them be more prepared. ALS had a little bit more proportion of training. And so this is the table 3 from the study that they look at kind of the first initial thing that I was mentioning. So did their training make them more comfortable and make them more prepared? And ALS felt more prepared regardless of if they had training or not. But the more training that they had, the more comfortable and more prepared that they felt, which I would argue is important for all of us on this call to recognize that, you know, maybe it's something that we need to make sure that we're doing for our providers. This is kind of the meat of the study where they kind of, they basically control for all the variables. So while I mentioned that ALS providers typically do more critical care, so you can say it's a confounding variable, it's a limitation of the study, but what they ended up doing is controlling for all those other things. So number of calls, number of death notification, population of calls, all the things, you know, certification, call volume, area of call, so anything that you could really control for. What they showed is that you still had an increased odds ratio of 1.7 to have burnout associated with death notification. So that's controlling for every other variable that they measured. And then receiving the training decreased the burnout on a whole by 29%. So when you control for all those variables that can seem like a limitation to the study, they actually were less likely to be burnt out, and they, you know, with training, while giving the same number of death notifications. So it's pretty important study. I think there are some limitations. These are coming right from the study themselves. It was a survey study, so you have recall bias. So there's, it's not a multivariate analysis. It's not a, something crazy like that, but I think it was a pretty well done study to get some baseline information and kind of support the ongoing research of, PTSD and depression, and, trying to get resources for providers. One thing they also mentioned is that they wish they knew what the circumstances of the death notification. So was it a cardiac arrest that they arrived, did work, and pronounced on scene? Was it they showed up and the patient was, it was an obvious death and, they've been there for a couple weeks? Was it somebody that was brought to the hospital? So they don't know any of that information, and they propose that that could be something to consider as far as what's more likely to get burnout. And confounding variables, the other thing is what system are we comparing? And now, while I mentioned that they controlled for all those variables, it's also different when you still compare, Irvington versus, going down to Gloucester County. Those are even if you were to control for all those variables, it's still very different people and very different populations. I would say, as you could probably see the bottom of my screen, yeah, it's a limitation, but I would argue that the data that we got out of it is still important, and still recognize that there are some, that burnout's a thing, and training is helpful. So I didn't want to just leave it at that. I wanted to kind of bring it up as a what can we do about it, because mental health is a big thing that I think is important for every healthcare provider. And this is something that they also talk about in the discussion of the paper a little bit. So, creating a wellness curriculum, which has been drilled into all of our heads over the past few years with everything going on. And it has to be individualized. So, giving people time off when they need it. Obviously, then you can't run a business. So it's, I'm not trying to tell you how to do your jobs, but, trying to allow for time off or EAP or having, a life outside of our jobs are all important to wellness, and everybody's wellness is a little bit different. So that's why I say, what really can we do? So this is a training, an ER study that was done to figure out how to train people how to give a death notification, but also has shown that it will decrease burnout in doing the same thing. So the article's here, and I can send it out. But basically, you want to gather everybody. And again, this is geared more towards ER. This was done in the ER, but you can kind of have the same idea in the pre-hospital setting. So, can you gather the family in one room and have PD there to help you? You don't want to have people coming into the room while you're trying to give them bad news. Is there an RWJ EMS fellow on the scene that can help you kind of break the bad news? Identify who's on scene. Are there resources that you can get? It's the R, and I'm kind of going out of order. I apologize. But identify who's who. So who's the immediate family member? Is it the daughter, the father, the brother, the spouse? Educate them on what happened. So, okay, this patient has, dialysis and they're BKA and they're pretty sick as it was. And, we think that, they had a lot of problems to going into this. And while we did everything we could, their chronic medical problems, the traumatic, event, the chest trauma is what led to their cardiac arrest. And then a very important point that's been drilled into me is use the word died or death. Don't say pass away, because they don't believe you. And this has been studied time and time again. And basically you have to, and it's why they say verify, say that person died. They are no longer with us, but they died. You have to say died or death, otherwise people don't believe you. Space, so you have to give them a little bit of silence to internalize what you just said. And then inquire, do you have any questions? Can I have the police get arrangements for the funeral home, things like that, especially as EMS providers. Like, you don't, and even ER physicians, you don't have the luxury of sitting in the room for hours on end. Unfortunately, we still have a job to do. So see how you can not only just expedite them getting better and them getting the resources they need, but also how you can get back to work. Nuts and bolts. So funeral home, medical examiner, again, this is more related to the ER where I can have social workers or nurses help me out with that. But, you know, if you need to get PD involved so that you can go back onto the road, it's something to keep in mind. I'm sure I'm not saying anything you guys don't already know. And then give contact info. I don't necessarily agree with this. They said give your contact info, so if they have questions. Really, if I'm in the ER, the nurses know how to get a hold of me. In the pre-hospital setting, I'm not getting anybody my phone numbers, but that's the end of the thing. Other things that we can do as a as a company, as a support staff, as supervisors and ER physicians, you can do critical incident stress debriefings, especially after, it doesn't have to be that major shooting or the major, event. Just being able to be the supervisor that goes, okay, do you need a minute to talk about it, and bringing them off the road. And something that they had suggested, which is not reasonable in my opinion, is trying to have crews available to fill in those gaps, which, as we all know that there's a paramedic shortage and an EMT shortage, that's probably not the most reasonable, but allowing them to be out of service for a few minutes to get them, to, debrief a little bit would be great. EAP, again, it's free therapy provided by insurance companies and companies. So it's a good thing to make sure that these people have developed good coping skills. Not drinking alcohol constantly is always a good one, but, having your support system, having hobbies outside of it, are always things that, this is, again, it's not falling on deaf ears. We all know about this already. One of the last slides is just kind of showing that this has been something that's been talked about for years in the EMS literature. The CDC has some documentation on how to prevent and control and understand all of that. GEMS has this article, I think that was actually from like 2006, of how to develop resiliency, the silent killer in EMS. Most of you on the call have been doing this a lot longer than I have. And, I got my first certification in 2009. It's just something that I think this article kind of highlights is that, the more cardiac arrest you go to, the more likely you're going to have burnout. And then on top of it, we just kind of need to address that in general. But that's about all I got.
Yeah, I think one of the important things that you mentioned was specifically, resilience and wellness, having a system established. Do you have friends within the industry? Because also sometimes, some of us don't have spouses at home or friends at home who are within the industry, and they may or may not understand what's going on. They may or may not understand, what you're going through. So having someone out there who is able to actually talk to, and talking sometimes is all you need. I posted in the chat group the naemt.org document that you were referring to. I actually posted it before I knew you were going to go over it. But that's kind of the document that they put out. There's also something called the Code Green campaign, which is EMS specific, and that's about mental well-being and mental wellness as well. It's just, I think it's codegreencampaign.org. Yes. And then the whole critical incident stress debriefing. I've seen it myself where we've had strings of, bad pediatric cardiac arrests because those always get underneath our skin. And, the supervisor will come by and talk to the crews and things like that. And those little things make a difference. But, that's not only the only time that you should be coming by, talking to people, when everything is good as well, to establish those communications, because you don't want to meet someone for the first time when something bad happens. Anyone else thoughts?
Can you hear me?
Yeah, hey.
Hey, how are you? Good. I think a lot of this comes with emotional maturity. And as time goes on, you realize what's good for you, what's not good for you. You have to live healthy. And when you mean by living healthy, it's not just physically, but it's emotionally. So I call it my Bob time. So I like going out and exercising, hanging with the kids, doing my dog therapy, running the rescue. And when you just work constantly and you're surrounded by 24-hour shifts and 36 hours, 48, 60, and then you're eating unhealthy, you're gaining weight, you're getting depressed, and then you have all these stressors of work. It's a big circle that you have to stop. And until you realize that and do a little reflection, you can end up in some ugly places.
Yeah, having a predefined outlet on what to do, like, maybe that mentor who, or your FTO who, when you first started, they might be that support that you need.
Yeah, I mean, I still talk to some of my FTOs from when I was an EMT in 2009. Like, they are still on the road doing this all the time, and there's stuff in the ER that I'll even talk to them about because we went through it together, and having that support system. And there's certain days that I'll take a day off and be very limited on emails and stuff like that. And then on top of it is these trainings. Like, I try to, as much as a lot of it's the same stuff, like all the wellness stuff seems to sound the exact same every time. You never know when you're going to get something different from it. And anybody that listened to New Jersey ASAP last week, there was a few lectures about that. And it kind of highlights everything we talked about, and it's just good to have in your wheelhouse.
Yeah, you'll see a lot at a lot of the conferences now. The Project Green is there, NEMT is there, and especially for EMS, we kind of bleed into firefighting as well. So the International Association of Firefighters also has some wellness resources out there for EMS, and that's a big thing. The mental health being ready. A lot of the times for death notifications, especially like if it's a cardiac arrest or something, you really need to kind of gauge the room. One of the things, what I do is I try to bring, after, we've done all that we can, I don't call it right away. I'll actually bring the family in. I'll let other people know, it's like, listen, I'm going to go talk to the family. I may bring them in. I'm going to offer to bring them into the room if they're not already there. And I tell the family, what do you think is going on? And I tell them, like, your grandmother, your wife, your, whoever, they died. We're trying to bring them back right now. Because when you just say, oh, they're not doing well, why are you pumping on their chest? Things like that. Like denial is very strong. And, you start off right away. It usually makes a big difference. Bringing them into the room, for me, not everyone's comfortable with it. If you're not comfortable with it, don't do it. But for me, I feel like it makes a big difference. It shows that you're doing everything that you can. You want also everyone to be as professional as possible, and then go from there. There's some ancillary things that, maybe it's a criminal investigation, something else is going on that you have to work on. And, those are kind of like the little caveats. Sometimes, if there's a police officer on scene or something, I'll tell them, like, listen, we're about to call this. Would it be better if we just brought it to the hospital, or, this is maybe another discussion, but termination of resuscitative efforts, that as well.
Yeah, witness CPR has been shown to decrease PTSD and depression in the families as well. So it's something that I think everybody should at least consider.
Yeah, it's that closure. Have it. You're actually like, you can be in disbelief, but when you actually see it happening, and this is one of the things that the TV has really hurt us. There was actually a poster. I don't know if it was fully published, but I do know that there was another article that was published specifically on the rate of ROSC and to neurological discharge in TV cardiac arrest, and it was like in the 90s, 99%. So people, you're pumping on their chest, and they're like, oh, they're just going to come back. But that's not the case in real life. In real life, it's less than 10%, and that's a very, very big, hopeful number. A lot of places are less than 1%. if no one has anything else, we'll wrap up Journal Club for this month. We are going to be bringing back interesting cases. We're going to do it a little bit differently. If people can email me with interesting cases, pay attention to like the presentation, some of the differentials, what happened. I don't need any patient information or anything because we're just going to be discussing the actual like medical problems. And I'll see everyone next time.